Thank you.
Take that. You. So, Andrea, would you please start?
Andrea Frostat.
Linda Thompson, City of Spokane Valley.
Kevin Freeman, City of Millwood.
Tony Smith, Agency Administrator.
Bob Blutz, Agency Health Officer.
Don Condon, physician.
Construction fraud led to a denial of justice and compensation for over 5,000 families who filed claims of vaccine injury. Since this fraud happened, roughly 1 million children have been diagnosed with autism. An unknown percentage of these cases are the result of vaccine injury. But the fraud reveals HHS' own expert doctors told them vaccines can and do cause autism in children. Also on September 20th, J.B. Hanley's How to End the Autism Epidemic was released. It hit the bestsellers list at Amazon, Barnes & Noble, and it sold out within hours. This book quotes depositions from titans of the vaccine industry, such as Dr. Stanley Plotkin. In the quoted testimony, the lawyer asked Dr. Plotkin, "I'm asking you as a scientist, can you make the statement that vaccines do not cause autism if you don't know whether the DTaP or the Tdap cause autism?" And Dr. Plotkin replied, "As a scientist, I would say that I do not have evidence one way or the other." And then in another deposition, Dr. Kelly explains why the government is misrepresenting vaccine safety. Lawyer, do you agree with the statement that vaccines do not cause autism? Dr. Kelly, no. Lawyer, do you know the position of the American Academy of Pediatrics about any link between vaccines and autism? Dr. Kelly, yes. They also say there is no proven association. Lawyer, do you agree with the position of the American Academy of Pediatrics? Dr. Kelly, I agree with their position as a public health measure, but I don't agree with it scientifically. What does I agree with their position as a public health measure mean? Dr. Kelly knows and has testified under oath as an expert scientist that vaccines can cause autism, and he is telling us that public health considers high vaccination rates more important than any child's life. We have new science from the past decade showing just how vaccines can injure and lead to an autism diagnosis. And we have the top autism doctors in the nation swearing under oath it happens. Vaccines are not the only cause, but we know the top scientists in the country on the subject knows. They are a major cause, with autism rates exploding from 1 in 10,000 to 1 in 36 in just a few short decades. This is a tragedy that can no longer be ignored. No vaccine-targeted infection ever caused harm like this. Should Spokane Regional Health District be hosting vaccine clinics when there is no way a child's susceptibility to vaccine injury can be assessed?
Thank you, Jacqueline.
I just have 2 more sentences. As elected officials and members of Spokane Regional Health District responsible for the health of almost 500,000 people, it is imperative you stay as up to date as possible on the interventions you support. I strongly recommend that you read this book. Visit childrenshealthdefense.org for full details on the legal action being taken. Thank you.
Okay, thank you, Jacqueline. Jason, is it Burley? Jason?
I'm Dr. Jason Kinley, naturopathic physician, Spokane, Washington. Recently in the news, as of today, the CDC is estimating 80,000 flu deaths attributed to last year's flu season. The concern I have is with how they're estimating these flu deaths, because they are not mandatory reporting for adults. It's only mandatory for children, and that started as of 2004, I believe, with the CDC with the outbreak at that point. The concerns that I have with this is that they're looking at death certificates, and they're using pneumonia and influenza, and then they're also looking at respiratory and cardiovascular causes, but they are not able to directly link both, which means the error for over-reporting flu deaths directly attributable to the flu as opposed to a secondary cause may be gravely overstated. The second issue with this is they're not reporting nosocomial versus community acquired. We do not know how many of these individuals were already in a hospital setting when they acquired the flu or some other illness that may have contributed to their death. The reason I bring this up is that currently the Spokane Regional Health Department and Spokane Public Schools have opened up vaccine clinics that were originally supported to be during the daytime. These are optional. Parents can opt out. My concern is that Spokane may end up in the same situation that Pensacola, Florida is in right now. They had to stop their vaccine program during the school day because they were vaccinating the wrong children, which means we were giving a medical intervention without consent to children without their parents present. I have major concerns that we are spending our taxpayer dollars to be doing this. There are other locations if people wish to choose to receive vaccinations that should not be done on school grounds. We are not supposed to be mixing health care options during the school day at school. Those decisions need to be made between the parents and their provider, not based on a sheet where we increase the error from injury or potential problems. We already know that the third leading cause of death in this country is medical error. We don't need to exacerbate that by doing that on school grounds. So I ask that you please revisit this, talk to the schools, find another location that is not there. I have attempted to approach the Spokane Public Schools to say that I would be happy to offer my services for free during their clinic in case a parent had questions, and their response was less than acceptable. They basically told me I could do whatever I wanted in my personal business. I didn't ask for their permission in my business. I asked to do it at a taxpayer-funded facility where my taxpayer dollars go. I didn't ask to provide an intervention. I simply asked to be there in case somebody had questions and they didn't have time to answer them. So again, I ask you to please take this into consideration, bring this up with the schools, and find another location for somebody who wishes to have that conversation and that intervention. Thank you.
Thank you very much. John Perard?
Correct.
Oh, good, thank you.
I am John Perard from Coeur d'Alene, Idaho. I run a business in Coeur d'Alene and Washington. And I first became concerned with vaccines in 1986 in a school where about 30 of us were vaccinated to go to a war-torn country, which I don't believe had any polio. I'd have to look back at that. And I don't remember the vaccines we got. What I do remember is one of the young men in my dorm, would have been around 24 years old, be a guess, became extremely ill. He moaned and sweat all night long and was in terrible shape. Probably should have went to the hospital, but he didn't. He did survive that. He did recover after a few days. That kind of made me wonder about things. And then in 1987, up in Canada, we went for a dinner at a friend's house, and we met a young lady, probably 10 or 11 years old, completely debilitated by a vaccine as a child. She was in a wheelchair, could not walk, speak, or feed herself. She ended up dying in her teenage years, 24/7 care throughout her life. So I began from there to start looking at some of the scarce science that was available in 1988 when we were pregnant with our first child. And I would go to the library, get whatever I could find. Dr. Robert Mendelsohn was one good and alarming source. And so from there I have followed this issue from 89 till today, which is quite a few years. And now there's a large amount of science available at the libraries and Google, the largest composite of knowledge in the world, and many places. So I have looked at a lot of great science. I want to make a point of not ignoring or underestimating, and this is from PubMed, and I'm not sure who wrote this, the role of anecdotal information in healthcare decisions is likely to hinder communication among decision makers and to retard their uptake of research evidence. Anecdotal information should not be considered as a replacement for, but as a complement to formal research evidence. If evidence-based healthcare is to meet its potential, the important role of anecdotes must be acknowledged, studied, and utilized. So I'd like to give you a fast anecdote written by my mother in 1959, so you can blame her for this anecdote. When I was 4 months old, she's writing in the first person about me, he started giving me my baby shots. When I was 5 months old, I had an ear infection, and from then on, I had a lot of trouble with earaches. When I was 1 year old, I finally got straightened out. I remember the stories as a child. My parents told me that I kept them up for 6 months straight. And I had a very sickly childhood. I raised 6 children that are very healthy, no vaccines. Thank you.
Thank you, sir.
Yes.
Rose? Gosh, Rose, I haven't seen you for quite a while, so I'm going to remind you, you have 3 minutes.
I've been busy.
Okay, thank you.
I would have liked to have been here to rattle your cages, as I have
Gosh,
the last 20
It doesn't
years.
rattle our cages anymore.
But
you know. Just stay within your
I
3
have
minutes
had a
and then it
very
will,
busy
okay?
summer. When did my time begin? When you started?
Oh, darn.
It's unfortunate that the time limits me. I'd like to expound on a lot of things, but I'm here to say that I know for a fact, because I once lived in one of the cities, the only fluoridation, U.S. fluoridation experiment that was ever completed in this country, and that's the Newburgh, New York fluoridation experiment. I lived in unfluoridated Kingston, which was the unfluoridated control. Needless to say, the reason you don't hear about that is that it proved, after its 10-year study was completed, that fluoride is a bioaccumulative toxin. A little bit won't hurt you now, but add it all up in a few months, weeks, or years, depending upon your exposure, and it is a ubiquitous environmental pollutant, as well as being in a base ingredient in most drug medicines and vaccines. And relative to that, you'll note that I wanted to speak on health. That's an old English term for health. It involves the body, mind, and spirit of the individual, all of which the Latin term mens sana in corpore sano simply means what influences this influences the rest, and vice versa. So what you imbibe, inhale, ingest, come in contact with, it all has to go through the liver and be processed. And whatever the liver, relative to its lack of nutrient-dense product coming in, will be limited in assisting you to maintain homeostasis, which is that steady state of health. I just quickly want to say that S. Mitchell-Tree and R.N. in Portland, Oregon, confirmed for me in 1972 when I was living there that the United States Public Health Service ceased recording the cause of death by the 70s because an RN in the state of Illinois disclosed that there were more heart deaths in fluoridated cities than there were in those that were not fluoridated. And I've got lots more, but anyway, that'll hold you for now.
Okay, thanks, Rose. Nice to have you back. Okay, continue. Let's go to item number 4, Chair Report. I see Karen. Do you have your joke of the month, please?
I do. You ready?
Turn that.
Oh, I'm sorry. This is a good one. Why did Beethoven get rid of his chickens? Because all they said was bok, 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 bok.
She must have got that from Dr. Lutz. I almost have to
That was
believe
on my
that.
own.
That's on your own?
That was on my own.
Okay. Okay. A couple things within your packet. You have the emergency contact cards that's been updated. for your information. That's extremely important, so you can keep it on your bedside in case you have a health problem with that. Also, within your packet, you see a notification of the Healthy Youth Symposium handout, which is in your packet. And if you can attend that, it's really going to be a great meeting, and I think that we need to hopefully be so involved in that. Then the last thing that I'm going to take the chair's prerogative, as all of you are well aware of, is that Torney's going to be leaving us in January. And I just want to say a few words now, because I know that we'll all have an opportunity later on prior to his leaving, and I know that he's probably going to speak a little bit today about that. But, as the chair and a board member for the last 7 or 8 years, I certainly have appreciated Torney and our relationship, our positive relationship, and how we've been able to work together. There are times when we've had some differences, but for some good reason, we've been able to iron those out and resolve whatever the problem may be relative to the health district and towards what's is best for the agency. And our friendship has simply got stronger during this time, and our relationship and respect for each other has grown also. So, you have new ventures ahead of you, Torney. I can speak to that. When I retired, my ventures turned out to be being on a council and then being with the health district. Now, whether or not that's a good venture, but it certainly was. And I can just say I want you to enjoy every single second that you have of your new freedom when it happens. But there's a PS to all of this. No, we made a deal a long time ago that you'll continue giving me golf lessons. And if you don't do that, I will let everybody know in the whole world how bad you really are. So with that, then, we'll go to the next item, please. Agency report.
We'll begin with Dr. Lutz. Oh, Chuck. Oops. Yeah, that's right. So as you know, I typically start my presentations with this, and again, I really like to emphasize that public health definition from the Institute of Medicine. It's what we collectively do as a society. And again, I emphasize the word collectively and society to assure the conditions in which people can be healthy. A couple of topics today. As you know, the last number of months we've been working on opioids as a pending community issue. We've had a number of meetings on a monthly basis, and we have a task force meeting that will be occurring next Tuesday, October the 2nd. We have about 80 invites out, and this really crosses a number of different sectors. I'm really excited about this because, again, I think that we've all identified this as a concern. We also all acknowledge that the only way we can do it is collectively. So hopefully we'll get good turnout. Hopefully we'll come up with some guidelines and some action items going forward. Another priority, and again, both of these are consistent with our agency strategic plan, is that of suicide and suicide prevention. Specifically, I just left a meeting about half an hour ago. We pulled together a number of community representatives, and we met with the DOH representative. She is the program manager for the state suicide prevention program. And the state's prevention program printed up probably last year. It's, again, as I mentioned with opioids, it calls upon the community to approach the issue from a collective impact approach. 4 strategies, and we presented her the data, our local data, which again are concerning. We've seen estimated maybe a 30+% increase using medical examiner data between 2016 and 2017. So of concern for us both as an agency and as a community. And so this is just the start of a long process, looking at the data and then determining what capacity exists in our community, where the needs are required, and then really, again, looking at bringing the community together to address the issue. So those are 2, again, major priorities for us as an agency and certainly for me as your health officer. The other topics that I'd like to talk about, somewhat new. We've heard, obviously, that flu immunization clinics are ongoing. We've actually had our first hospitalization for flu as of this past week. So it's here. And the guidelines for vaccination are no different than those from last year. The only change is that flu mist, which has not been found to be as effective in the past, and was actually sort of taken off the list of available sources of vaccination, it's now available. Now, that said, it's still seen to maybe not have the same efficacy as what you would expect with the actual vaccinations. So the guidelines that we have always recommended, the guidelines that are put forth by the CDC, are still the same recommendations that are being in place for this year. Olympia, I mentioned Olympia. As you know, I was appointed as the health officer representative to the State Board of Health, and I was able to attend my first meeting in August. And it's a really exciting opportunity to understand how public health law and regulations are implemented, and again, the work and the process to understand that whole effort. A couple of things, and every month when I go to those meetings, I'll bring back what we've talked about, but the items that were addressed were with respect to changing the WACs about food truck restroom distance. Okay, currently it's somewhat problematic for food trucks because the distance for an available restroom is limited to 200 feet, which makes it very, very challenging for some trucks to actually find those resources. So there's conversation about extending that to 500 feet, and of course, many parameters around that. Foundational public health services, again, we've talked about that previously. That's also what took me to Olympia in September to testify in front of the House Healthcare Committee work session. Again, looking at the importance of foundational public health services as a priority for public health. I was, again, really pleased to be representing not only health officers, but also Spokane Regional Health District, because we have been involved in 2 shared service projects. As you know, we've been working with tuberculosis, and we've been working with what's called the WTCN, the Washington Tuberculosis Control Network, out of Seattle, to expand both the network and the information available to the community around tuberculosis. We've also been the provider of services to some of the outlying communities for both assessment as well as investigations for communicable disease. So again, I was able to testify with Secretary Weisman, Jamie Bodden from Wasalfo, and a representative from the tribes on the importance of the legislature funding us for foundational public health services. We also talked at the State Board of Health meeting for rulemaking changes on WAC prenatal screening, on communicable and certain other diseases, specifically HIV testing, and then PFAS, which obviously, as we know, was a major concern up in the Airway Heights area. The Department of Health is looking at that and looking at coming up with some criteria that can then be used going forward to better understand the issues. And then finally, I'd just like to talk to you about what's being referred to as a Health Advisory Council. This will be coming forward next month for a resolution. A little history. When I was a member of NALBO, I was asked by NALBO to present to 5 local boards of health on what was called the Community Guide. It was a CDC evidence-based recommendations on certain community practices. And one month I found myself in Clark County, where Secretary Weisman then, as an administrator, had created an advisory council for the agency and his board, representative of community members who were then going to provide recommendations, sort of provide advice to the agency and the board. I was able to sit in not only on the Board of Health meeting, but also on the Advisory Council, and just really found it very engaging. Here were community members, experts from various disciplines and representing a variety of sectors from business to education, who were providing their in-depth, on-site recommendations and advice to the agency and the board. And I said, wow, this is something that would be really interesting to look at. Well, I find myself in this position now as a health officer, and I said, well, you know, we have great resources, and I'd really like to understand at a more sort of grassroots level what's happening out there. And so through both meetings that I've had over the course of the past year, as well as recommendations on people I should talk to, what I've, again, conceptualized is putting together an advisory council that would function to advise me, as your health officer, on issues which they have identified in the community, and then bringing back to both you as the board, as well as the agency, some thoughts. Here are some things which they're concerned about. Are they concerns which resonate with us? And are they things which maybe we should take on or look at more closely? And so I've met with many of these individuals. What will come in front of you next month is a resolution to formally bring that Health Advisory Council together. And the intention is for me to meet with that group about 5 to 6 times a month. 5 to 6 times a year, excuse me. They would not want to meet with me for 5 to 6 times a month, that's for sure. But 5 to 6 times a year, during which, again, I really want this to be a very organic process. I will provide for them background information on, again, why I wanted to develop this, on our strategic plan, and on the community's health assessment and the priorities that have been identified. And then let them run with it. Let the group run with it. And if those priorities resonate with them, great. And how can they provide sort of that grassroots, on the scene kind of feedback to me to let you and the agency know what's working and or what's not working. Is there something else that they're really interested in? Run with it. You know, I do not want to drive the train. I want to be just a member of the caboose, I guess. I don't know. So anyway, a little bit of information about the Health Advisory Council. As I mentioned, we'll be bringing that back for consideration next month. And you know, I finish with that. And any questions for me? Yes, ma'am.
I have a question about who you contacted about the possible Health Advisory Council. Who did you contact?
You want names? How about what I can do is, why don't I print out a list of names? I think it'd be easier than for me rattling off names if I just print out a list of names of people that I've contacted and then distribute that. I'll maybe ask Ann to send that out. And what I've tried to do, again, is to look at community members, look at different sectors, for example, somebody from business, somebody representing elected officials, somebody representing education, somebody representing healthcare. And these, again, are individuals who have been referred to me as good representation of those different sectors. Is it all-inclusive? No. But it's a start. And the idea is that, as you will see with bylaws that are being generated, the idea that this would be a group that would convene, as I mentioned, 5 to 6 times a year, not a month, and then people would rotate off and always open to new membership.
I was just asking because we have a lot of committees, we have a lot of people doing a lot of work at the grassroots level and all these committees, and trying to figure out who should be at the table and who's making decisions. And, there's a lot of different silos and agendas going on, and I just really encourage us to really work together because bottom line is we've got to help families. We've got to do a lot of grassroots work, and I just want to speak up for that.
Point well taken. Thank you. Yes, ma'am.
So back to the food truck issue. I'm just curious, where did that end up? Was that they are going to do 500 feet? Or you're talking about?
I will defer to EPH at this time. The status?
It's in discussions right
Yeah.
now. The food code is open for review, so it's been taken in as a plan to be considered.
Yeah, again, the process for me is really interesting. Again, the work that's done behind the scenes. And so what was presented to us was a request for a rulemaking change, and then some of the evidence as to why this would be beneficial to individuals and the concerns expressed likewise. Good, thank you.
I would like to also send a kudos to Dr. Lutz's way that he did a very good editorial in suicides, if you happen to read that in the paper. Very well done and to the point and very comprehensive. So I don't know if you can get another copy of it, but it was, again, Doctor, it was well done. So thank you very much.
Thank you, Chuck. And I would also actually commend the assistance of Kim Papich
who, again, we worked collaboratively on that. She's really good at wordsmithing and saying, well, I don't think I like that word there. So it was a collaboration, but thank you.
Okay, well, thank you, Kim, for a job well done. You probably did all the work when I think about it, so.
No comment.
No comment, okay.
Linda Graham will do the legislative piece next.
Sure.
Hey, good afternoon. The focus today is going to be on the development of the Board of Health's legislative agenda. So in your packet was what I'm calling the third draft. First of all, for those of you who are newer, I want to describe the process we use. It starts with me working with our various partners throughout the state, DOH, Wasalfo, heart, lung cancer, you name it, and talking about what are the key issues out there, what are they looking at in terms of priorities in their legislative agendas. Then I put together a first draft and take that to the policy committee. They met back in August and we discussed some options there. What's in your packet was my best attempt to kind of capture where the conversation went with the policy committee people. And then we will have some discussion today and get some input from the full board, find out what kind of research you might need or further information on any of these items, add items if you want. We'll come back in October and refine a little further, and then we'll bring it for a vote to the board in December. So as I said, what you have is kind of my attempt to capture the conversation with the policy committee. I do want to note a couple of minor changes with the descriptions to the tiers. We have this in 3 tiers. The first one is issues of highest priority. And the language change was really around trying to focusing on issues that have a broad impact on the public's health. The second tier, the main difference there is these are really priorities that have a substantial and direct impact on our operations and our programs. Last year, the second tier was more around issues being led by others that we will collaborate on. Pretty much everything we do is led by others and in collaboration with others, so it wasn't really working too well. And then the third category is issues supported by the board, but we'll do less activity on those. So the highest priorities, there'll be the most activity from me on the board, and then a little less on the second tier, and then the third tier, mostly monitoring and diving in where necessary. I just want to highlight a few things in terms of the issues on here. Foundational public health services, this is the absolute #1 priority for DOH, for Wasalfo, many others. If you recall, this does build on the ask that was made last year of the legislature and the funding they did provide. And this is part of a multi-year strategy to increase funding to public health. The second issue is Tobacco 21. It's back again this year. We've been pushing on this for a few years now. Hoping this is, we're going to make it this year. This is the #1 priority issue for Attorney General, the Governor, for Department of Health. It's high up on their list, and for us as an agency. A reminder that tobacco remains #1 cause of preventable death in the state, and that while we've been pushing on this issue for 3 years, we need to keep up that push. Full disclosure, I did kind of push back a bit on the policy committee to try and get this to the highest priority category. So it's in here. It's up to you to have that discussion. Suicide prevention, the category here, the focus here is really on putting in some foundational elements for a statewide system to really address suicide prevention. Oral health, this category is very similar language from last year. The biggest difference is DOH is putting forward an ask to have a state dental director put into place to manage efforts around that. And then in the second tier, I combined issues around tobacco, vaping, and marijuana. I don't know how much the Board of Health is aware of the tobacco funding or the lack thereof that we've had in the state. A lot of people assume that tobacco settlement funds are still in place and still coming to public health. They aren't. Very little is coming into prevention efforts around tobacco and vaping. So that's a part of this, is trying to increase that funding. There's a tax on vaping products, and then the youth marijuana prevention funding. We are slated to get up to 10% of the second tier of revenues appropriated to public health, and they have not been approaching that 10%. So have this in here trying to increase that funding. The STD statute modernization, you heard about this a couple of months ago, maybe even longer, when Lindia gave the report about disease prevention and response, and Lisa St. John talked about some of the changes around HIV and that it's a different world than it used to be. And so really trying to update the statutes for that. And then finally in that category, the prescription monitoring program. Last year, there was a bill that mandated that prescribers use the system. This has been a real issue for our opioid treatment program. They're not able to get really accurate information because they're not using it in a timely manner. So the ask here is for additional funding so they have more staff to actually enforce the mandatory provisions. I'm not going to go through all the things under the third tier. I'll let you kind of skim through those. So like I said, this is really an opportunity, kind of a first look at things, provide some input to myself and the policy committee, ask questions and those kind of things. So Brianne, do you want to lead that discussion?
I do. Thank you. So first of all, sometimes there's a difference in perception of staff and the committee. And so the one that, at least to me, was the Tier 3 is not that we were supporting as issues of interest to us. And so it was, is it interesting? We weren't necessarily taking a position on it. And so, but there are things that will impact us regardless of what happens. And so that's currently worded as if we're supporting those things, and many of us probably do, but I just think it should be more neutral. So I throw that out there in terms of where we came from. But what I wanted to do is find out from people on these issues, particularly in Tier 1 and Tier 2. Are you tracking with us or not? I pretty much, maybe except for the Tobacco 21, was the consensus of the committee of what tier to have these issues in. We did not rank them within tiers. So the fact that one's listed first or not, that was not a ranking. So my question will be, first of all, I'll ask if anyone had any questions about specific issues anywhere on here. Yeah.
I'm interested to know on the homeless, the discussion, and just my opinion is that that should be at a higher tier, because if you look at some of these other things, we can maybe save some time and money if we get youth when they need us. Then we may not have to worry about some of this other stuff, suicide prevention and tobacco and drugs. So I guess my question is, how did that end up on the third tier and not higher up?
So let me ask a question, Evelyn. So one reason sometimes things are on the third tier is if there's not any actual legislation going on at the legislature, but I don't know if that is the case in that one.
On that one, because of the way it's worded and it's in the current stance of things, that was the case. I'm still working with different agencies and nonprofits in the community to kind of find out what is the specific ask within this. I probably can come back in October with a lot more detail for you, and then we can decide then, because that has been part of it, is there's really not a good, solid, specific ask, it tends to be a lower. So.
Any other questions? I would agree with Karen in regards to the homeless youth, but we need more information in order to move forward with that one. Even though it's a Tier 3. So.
Yeah, and again, it's on Tier 3 not because of importance, it's because there's no ask yet, so that could change.
Any other questions, Linda?
So one of the things I'd like to see integrated is keep funding coming. Instead of, like for suicide prevention, I remember doing the QPR training 25 years ago. Question something, refer. What is it? Persuade. So question someone, are you needing help? Persuade them to get help and refer them somewhere. And the thing I keep seeing is that it seems like we're not advocating for sustaining funding for some of these things. We say, well, we've solved the methamphetamine problem, now let's move on to opioids. When actually, methamphetamine never went away, and opioids have been here for a long time. So I'd like to see in our language somehow about sustaining efforts. And I think that really has to do with one of the very last ones, which is health equity. When we look at communities who do not have the resources, do not have, they live in a food desert, or they don't have access to healthcare or transportation to get anywhere. I think that we have to look at that because it does affect a lot of this. And I'm always an advocate to move the advocacy for the tobacco, vapor, and marijuana prevention up, because prevention is the key on a lot of this. And until we start focusing on prevention, actually a continuum of prevention, treatment, recovery, law and justice, and health, I don't see how we're going to move forward on solving a lot of these issues. So I would just like to see that be part of it.
So two things. First of all, we'll, in a minute, once we answer any questions about individual things, I'm going to invite comment on moving tiers. So
okay.
Just so you know.
Okay, very
But
good.
the second thing, just to clarify, Linda, when Linda talks about sustainable funding, is that fit in the foundation of public health services? Because that's mostly a funding issue, but I don't know if you could speak to whether or not that fits, or we need something else, or maybe more language under the foundation of public service of continuing the funding that we already have.
We can certainly kind of tweak some of the language to make sure that's a clarity. The Foundation of Public Health Services is making sure that there's sufficient funding from the state that every jurisdiction in the state can support a base level of public health services. So it's kind of a whole concept around that. But it's not saying stop funding on these things. It's just a particular focus on trying to get funding levels up so that we're all at the same capacity and the community has the same services. But we can look at tweaking that kind of language or finding another way to bring in that issue of sustainability. I think that is one of the difficult things when you're working on a legislative agenda. You're trying to focus on some very specific things. And sometimes it's like, oh, that we can forget about anything that's not on there, which isn't really the case. And that's definitely something I always talk with the legislators about is don't forget about, just because it's not here, don't forget other things. So.
Well, yeah, I'd invite you to just put a little bit of language that says sustainable funding for all programs related to health, continuing that, something like that. Because I think that reflects probably our priorities.
Is that what you're looking for? Linda?
Yes, because, for example, we're going to have, West Central is going to have, they have a Community Prevention Wellness Initiative Coalition, which is some of the marijuana dollars. They're going to have some opioid money from the some opioid money coming through Division of Behavioral Health and Recovery through those Community Prevention Wellness Initiative coalitions. They're going to have a Drug-Free Communities now, which is federal money coming through, and then I believe the Neighborhoods Matter project is going to be in there. So what you have is one neighborhood who has a lot of resources, which doesn't particularly have to do with advocating for the legislature, but being aware that some communities have all this. East Valley has a coalition, and the rest of the county doesn't have anything as far as substance abuse and violence prevention goes. And so I'm thinking, as we're looking at, I love this idea of fully funding the set of public health capabilities, but there has to be talking about, a lot of folks still think 502 money, that there's prevention dollars everywhere, that we're just rolling in the money with the excise taxes, and we're not. Our 6-county region through the MCEP gets $250,000 to cover 6 counties. And people are shocked when they hear that. And so I just always look for ways to educate our legislators and the public that we aren't asking for all this other money when money is coming already, that this is critical needs and we have to sustain this.
Thank you.
Okay. Any other questions about specific issues, and then I'll try to lead us through which tiers.
Sure. I guess mine's more of a generic question here, so forgive me, I'm new here. So is this an internal document, or is this something that we actually hand to our legislators?
This will become an external document.
So it'll become external.
And one of the things we're planning on doing is having in December a session with some key health-related legislators, local legislators, and come and talk with us, where we would present to them, get their feedback, and also find out from them what health issues they're going to be advancing. So that would be in December. So yeah, it is an external document.
And I guess on the opioid, I hear a lot of discussion, a lot of topic. It's kind of all over. But when I look at this agenda, it's just one little item on here. So is there something else that's opioid related? I feel like it's a very large issue in our community, but not really a large staple in our legislative platform. is that from just not another ask that we have?
Yeah,
going,
we're,
or-
I think, again, I'll defer to Linda, but I think the reason it's so narrow at the moment is that's the only one we're aware of that's currently going to be pending. So we're trying to tie our legislative agenda with things that are already happening, and focusing on that, as opposed to writing our own original legislation and doing that. So, but I don't know
Yeah,
if that's the
I can
case.
build off of that one. And keep in mind that this is very much a draft, where this is an evolving process till we get to December.
They're draft.
So that's why these discussions are so important. Also notice under what ended up under Tier 3, which we could argue maybe needs to go somewhere else to a higher tier, is mental health and substance abuse. And that really is looking at the larger issues of mental health system and the substance abuse system, and continuing the efforts. There was a lot of legislation last year on those issues. So this is really about continuing those efforts to refine those systems and target those areas. So that kind of an issue you're talking about, the larger opioid, really kind of comes under that category. And we can look at combining things too, if it makes more sense. So.
If I'm understanding you, Linda, is it fair to say that partly because we're just on top of it early in the system, but as we get closer to the December, there might be more concrete asks for the mental health, substance abuse, for the homeless youth, and also, frankly, health equity, which is a big priority for our local health district. Is it potentially that they will come to the light then, and then we can think about putting them into Tier 1 or 2?
Yeah, I really see October as a discussion about as things have evolved and I've gotten further information from our partners and can refine some of these asks. It's really, then it would be refining what that language is and refining the tiers amongst those. So
So if there's anything else that comes to mind, Andrea, you have another question?
No, but Linda, on the mental health and substance abuse, that upper tiers that kind of goes along with the other.
it is possible we could combine those two or put them next to each other, just so it's clear that we're not just talking the smaller prescription monitoring program, or really are talking bigger issues. And that was on a higher tier last year. And I may have gotten it wrong in the policy committee. It was kind of a lively discussion. So
I think, Linda, you got it right based on what Brian was trying to do, what we were trying to do in the policy committee by sculpting our legislative agenda to what was available to directly advocate. If there was a House bill or a Senate bill or some piece of legislation or some action that was going on directly that we could get behind and push or be a proponent of, I think that's what we were trying to target. I don't think that these items being in Tier 3 they're of interest, but there was, as Brian said, there was no direct legislative ask that we could tie to. Now, I think it's a good suggestion that maybe we realize that some of these things like substance abuse and homeless youth are things that are of great concern to the board, but if we get something that comes forth from the legislative agenda in October, that we could say, oh yeah, now there's this, we need to move that into a Tier 1 or Tier 2, because
Right,
that's where we're feeling.
yeah, and keep in mind that, so much of what we do, like I mentioned earlier, we're collaborating with others and partnering and needing to build off and find commonality amongst all our legislative agendas. DOH comes out with theirs relatively early compared to other agencies, and that's part of why I'm not yet getting a lot of response on some of these issues, is because other agencies, they don't even talk about it. They don't even say we're thinking about until they have everything in place and approved by OFM and governor and all those kinds of things.
So in October, go ahead.
So I have just a quick question, Linda.
Yeah.
We talk about advocating or being partners with folks that are being proponents or proposing legislation or things like that. Last year, a number of the Valley representatives tendered forth legislation regarding vaccines.
Mm-hmm.
It's obvious that our representatives, Senate, House representatives, are willing to take public health concerns to the legislature. Should we be, as a health district, actively working with our reps and formulating legislation for some of these things?
That is part of the process of checking in with what's on their radar, what's of concern for them, and those kinds of things. And interesting discussion on the immunization stuff that was put forward last year. It was very much, let me put this simply, not the public health perspective. So it wouldn't be something we would have gotten behind.
Obviously, but what I'm saying is that that was obviously something that was done by others. Shouldn't we, as a leader in public health, if we have an issue with, that we've, as the board feel, or as the district feel, that this is a concrete issue we can get behind for homeless youth, or we need to start a program for looking at that, shouldn't we be asking our legislator to advance that if nobody else is doing it?
Yes, we very much can do that. I think that's an idea in particular that's in the works coming out of our strategic planning process, is really looking at what are the community priorities we've identified, what are the district priorities we've identified, what kind of policy efforts can be done around those, whether they're local policies or state policies. And then if there is something coming straight from the health district that we want to champion this, that certainly is a part of what we can do. What part of that process would be then reaching out to all our partners and saying, we can't carry this alone. Who can help us out? So it kind of goes both ways. That makes sense?
And I was just going to say, I think that's a fabulous idea. It's slightly different than this. This exercise is what's going to be proposed and what are we going to be for and against. But we would have to start earlier in the year to do that. But I mean, we were working on the suicide prevention, I think, as a district. Homelessness, the opioid, that's the sort of thing that we say, here's the gap. Nobody's bringing that bill. Come on, legislators, help us develop one. So I think that's totally within our policy committee. And if people have a particular bill that they wish they would see that they're not seeing here or not hearing, let us know in policy committee, which is Linda, myself, Kevin, Josh.
Who else is on your committee?
Kate and Josh.
Kate
And Josh.
Okay.
Yeah. So that's great. So people really have something. So I appreciate that.
Yeah, and if I could just kind of build off that a little bit, part of what I do during the year is meeting with our legislators and really trying to educate them on the public health perspective and educate them on issues and those kinds of things. In some cases, it's more effective than others. And so legislators will do what they want to do regardless of, how much we can champion an issue, so.
And you'll have an opportunity, there will be an update before our October board meeting, is that if I'm understanding correctly?
There is.
And so that'll give you more information so that we can make a more intelligent decision as regards to what's going on. So.
Can I say one last thing?
Sure.
So I was going to do another little exercise here, but I think I'll wait till October where we have more information. But be keeping in mind, if you feel strongly that something is in Tier 1 and should not be, or should be, same on 2, and it's great discussion on some of these issues that are in Tier 3 because there's no specific ask yet, but if we want to figure out how to get them into Tier 1 or 2, that's what we'll be looking for in October.
Yeah.
And the last thing I was going to say, because there's several people in the room that are very interested in vaccines, vaccines are not an issue on our legislative agenda in any tier, and we're not aware of any legislation either expanding, reducing, anything like that. So I just want to let people know, because people have been curious in the past of where we stood legislatively, and there's nothing going on with that as far as we're concerned.
At this point anyway. One last thing is just an ask of, is there any information here or any other information you're needing on any of these issues? Do you need any research, fact sheets, anything on any of these issues, or is everybody pretty comfortable with the level of information that's here? Because I'm happy to go get that for you between now and
But I would
October.
suggest that after being requested that you do that, you can go back and really consider, because I know sometimes on the spot where we can't come up with some of those things, be sure and get with Breen or Linda and what your concerns are, and they'll take care of it at that point in time.
And just a final note, Brian mentioned legislative forum in December. We're still working out the details of how exactly that's going to look and how that's going to work, how much time it will take. But the idea is we're inviting somewhere between 6 and 8 of our representatives from this community, those on health committees, appropriations, or leadership positions, those kinds of things. And so I'll be making those asks and seeing where we get with that. And policy committee is meeting again in October. So we'll be putting together the details on that.
Okay. Thank you very much,
right,
Linda
thank you.
and Breen and the committee. Good job. Okay, Tony?
Next, Mike, if you could give us an update on the Audit Exit Conference. go first.
Making hand signals to both of us,
Hi, thank you. I just want to point out that about a half hour before this meeting, we had our exit visit by the auditors. The auditors they spent quite a bit of time here this summer. They had to come and go a couple times. They were short-staffed a little bit, and so we really had to work with them on getting the results back from them. I do want to thank some board members that attended the exit interview. Dr. Condon, Councilmember Beggs, Councilmember Wick, and Ms. Fostad all attended the exit thing. I very much appreciate board members coming to the exit and listening to what the auditors have to say about us. The third part of the audit that they haven't done yet is the accountability audit. And what that is when they come in and they see our internal controls and how we're doing on cash, cash handling and that. And they're actually going to come back next week and start that because they don't have to give a report on that until December 31st. What they do have to get in by September 30th is our financial statements and our federal awards, which is our grants audit that they do over the summertime. And it needed to get in today, or not only are we in trouble, they get in trouble also. So we really worked hard. Kim worked very hard with the auditor over the last few weeks, Kim Kramer, the accounting manager, on making sure that we're meeting this deadline and getting it in not only for us, but also for them. They spoke high praises of the staff here and the help that we've given them, and that I can't believe this, because we're sitting around the room, they're talking about, thank you for being there and getting us all the information you need so we can complete the audit on time. And I thought, that's our job. That's what we're supposed to do. And they said it doesn't happen everywhere. So I don't know what goes on out in other entities, but it was very nice. They said some nice things about Spokane Regional Health District. As you know, on audits, there's exit items that they just sort of tell you, hey, work on these along the way. There's management letter items that they strongly suggest you work on them because they could become a finding later, and there's findings. So in our results this year, as we came out, there was a few exit items that they've talked to Kim about. Some were little things we could just change right away. Some were working on putting some processes in place. Under the federal awards, we had no findings. We did have 2 management letter items, and it mainly had to do, one, with how we code end-of-year revenue coming in. End-of-year revenue comes in, and as it comes in, are we putting it back into last year's 2017, or are you putting it in 2018? And the part internally that there was mainly on programs that had the grant carried over into the next year anyway, so it didn't really affect the grant budget or the grant dollars, but because our budget's January 1st to December 31st, they had specific spots they wanted those put in there. So in a couple cases in the SNAP Ed program, they gave some examples of this is where they want the money reported. We reported it one way or the other, but they wanted it a certain way. Another management letter item was some of the wording in the contracts. We send contracts out, and some of them are very specific about having the CFDA number, the entity's name, the type of award it is, and where it's from, what federal places through in its federal pass-through dollars, and some of the provisions that have to be included with contracts. And they had found that some were missing some of these provisions. We have since internally fixed that and make sure that they are getting all the proper provisions they're supposed to have and the items going through. On the financial statements, we did have a finding. However, it was a significant deficiency finding, not a material weakness finding. And the difference being is if having a finding of significant deficiency, we get to stay low risk. We're still low risk. Instead of, if it would have been a material weakness, we would have went high risk. And what the finding was on is a new, well, semi-new, GASB 45, some new accounting requirements on post-employee, other post-employee benefit that you give out. In our case, it's our PEB insurance. We have retirees that if they retire early retirees retire early, they can stay on our PEB until 65. We were supposed to, Kim and I had to go through and figure out how, whether this was material to us by going through there. And we sort of did the work on doing all this, the formulas they gave us, all the statements they gave us to work out, and try to figure out how many people we had in certain categories and how many average years they had left and whether there was going to be a chance they could retire early, and did all that work. And we sort of came up with the conclusion that we thought it was sort of immaterial. The auditors came in, gave us a different number of how to run it, and said, no, we think it's material. And so we had to actually go out and hire an actuary, do the work. We contracted with the actuary in June, but because he was working on a bunch of other entities, GASB 45s, he got us ours on September 15th. We got it into the auditors by about the 20th. Accurately, right numbers, exactly how it's supposed to be reported, but because of the timing, we got a finding as a significant deficiency. As they pointed out in the meeting, there was many of them that got the material weakness on that because they didn't do any work at all. So we sort of made the attempt work at it, and so we do know how to do it now. The other thing is, there was a lot of training on this at the Washington Finance Officers Association meeting that Kim and I and Paula were at last week. That's the term, last week. And the reason the GASB 78 is important is that's what we have to do next year. So we have to leave 45 and move on to 78, which is a whole new, same theory, but a different way of how you report it on your financials. So I'm very proud of the work that our staff does in the finance department of keeping track of grants and dollars and all this, and very proud of the way that Kim keeps the books and makes sure they're in, and we gave a great thing. The auditors were great to work with. It went very, very smooth. They had high praise of us. They have high praise of our where we're at financially, and that we have some reserves in place. And so it went pretty well. And if any other board members want to comment about that.
Any questions for Mike?
All right, thank you.
Good job, Mike.
Thank
and
you.
your crew, not just
crew.
people that do the work for you. Okay. Okay, anything else, Tony?
Yes, I would like to have Michelle Fossum give us an update on contract with Kalispell Tribe.
Oh, there she is.
Sneaking up behind you.
You're hiding from me, Michelle.
I do that. They teach you that in law school, you know, sneak up on people. But I just wanted to update the board on an expansion of a prior agreement that we had with the Kalispell Tribe. For those of you that are new, in 2014, the tribe was constructing a swimming pool, and they don't have the mechanism to do plan review and that sort of thing when they're constructing a pool, and they wanted to make sure and do it in a way that was going to be safe. So at that time, the board authorized us to enter into an interlocal agreement with them to provide them with those services. Now they're building 2 more pools as part of their construction on the West Plains. And they have contacted us again to see if we will provide services for them as they construct those pools. And there's a new lawyer for the tribe, so there's been a little bit of shift in how we're going to do that. It's going to be strictly hourly. We're going to do consultative work. They're going to pay us hourly according to the fee schedule, but we will not have enforcement authority out there because of their status as a sovereign nation. So wanted you all to be aware of that. We're very excited to be able to provide that service and make sure those pools are in a way that's going to be safe for everybody to be using them. So I'll take questions if there are any.
Okay, thank you, Michelle. Okay, Tony?
Good afternoon. A couple of things that I wanted to share with you. First of all, last week we were very fortunate to have Dr. Tony Eiton come and do 2 events for us, a breakfast event with community partners, and then to address our all-staff meeting. Dr. Eiton is currently with the California Endowment. He is a senior vice president there addressing healthy communities. He was here to talk to us about the work that we have been doing on health equity. I think he had a very positive message, and for any of you board members who were in attendance, would certainly welcome your comments on this as well. For our all-staff meeting, I thought he did, again, a terrific job. I have spoken to Better Health Together, who had representatives attending the breakfast, and they have an interest in potentially getting him back here at a later date to do something in a greater extent with the healthcare community. So anyone who attended want to make any comment on your perspective of his? Yes, Linda.
Well, I thought it was excellent presentation. A lot of times I'm shocked by the data. He said that in the whole nation, they had not found a less than 15-year discrepancy in the lifespan, or is that what it's called, lifespan of people who live in certain neighborhoods in any community. And so he showed in California, he showed a map, and it showed that the overlay of poverty and the lower life expectancy of the people who live there, and then services overlaid. I mean, I've seen that before with our health district, sharing information about it with different communities in our region, and it's just always shocking we haven't made any progress on some of this, that it seems to be getting worse and worse. And but really good information, and then talked about stress and how stress and poverty and lack of job stability and all kinds of things can affect our just individuals. I thought it was an excellent presentation. And I sat at a table with several young people. Of course, that's anybody now for me, but young people.
That very lightly.
I know. But you're over there. I was at, sat with Frida Gandy from the Martin Luther King Center, and Tara Dowd, who used to be with Native Project, and they were not surprised at any of it, which is really sad. Because that is just part of what happens in their community, and so I just think we have a lot of work to do. But it was really an excellent morning.
I'll just add, I thought it was very inspiring, and particularly he was able to present data and language that was accessible to the people who live in the higher life expectancy zip codes, so that they might do something about it. And it was a great mix of people there. I thought your team did a great job of getting a breadth of community representation and leaders, and I think most people left there thinking, okay, what do we do next? And I know you as a health district and team are working on it, so I'm strongly supportive of that work. Thank you.
Thank you both, and strongly encourage any of you, if Better Health Together is able to bring him back, that you attend. It is certainly worth the time. Second item is that as I prepare to resign from the agency, or retire from the agency, I will come to you in October and December to talk about processes that we're working on as an exec leadership team, actions that we are taking to assure that it is as smooth a transition as possible, and that you are well aware of the kinds of things we're doing. And then finally, Chuck, thank you for your kind comments. I am horrible at talking about this in front of groups, so it has been an honor to represent the work done by everyone in this agency. It's not about me. It's about what people have done here to make this a leading jurisdiction in the nation. And I feel so proud to have been associated, and we'll miss it greatly.
Thank you very much, Tony. Item 6, the consent agenda, the meeting minutes from July 26th to 18, voucher July 1st to 31st, 2018, and August 1st to 31, 2018. I think I'll make a motion to accept both of those at the same time, please.
I so move.
Second.
Any discussion? All those in favor?
Aye.
Those against? Thank you very much. The next item, item 7. By the way, Green, aren't you kind of proud of me? I'm in sequence. I followed exactly what I'm supposed to be doing today. Yet there's a little time left. I may still screw up on that. There's a resolution 18-04 authorizing the formation of a Board of Health Transition Committee to oversee the candidate search and selection process in Spokane Regional Health District for the administrative position. As most of you are aware, that Tony is going to be leaving on January the 17th. This probably is one of the most important projects that this board can be involved in. Looking at a transition period, I need to tell you that Anne has absolutely done an unbelievable job of being able to look at all the different phases that we're going to be looking at. Beginning in September and going almost to the end of March. And we're not quite sure that at that point in time where we will be in regards to the recommendation. I just want to assure the board that on every opportunity they have, you will be informed of what the progress is and what we're doing, and making sure that staff is notified in the same manner so that there's transparency throughout whatever we are in the process of doing in selection. And you will be given the opportunity, not only as a board, but the staff will be given an opportunity to visit with the committee, so that they'll be able to speak to for the future of the health district, where they feel that we ought to be, any regular concerns they might have. And again, it's a very time-consuming committee, but the ones that were selected are simply very willing and able. They're quality people, and they're very willing and able to go ahead and spend the time in order to make sure that we have all the bricks in place to do the job. The sequence of phases you have in your packet, I think you'll notice that when you start going through them and what's going to happen with the committee, that it's going to be a yeoman's job for them to complete it. But they are committed, and we'll be meeting at least once a week, if not sooner, if it's necessary. More, if not, if it's necessary. But nevertheless, they're willing to spend the time and effort again. But we will be looking and requesting all types of input from staff and from administrative staff and so forth, so that we are doing it in a manner that's there. So this is really an important committee that we have formed. And hopefully, if you have any questions regarding that, I'm sure there's committee members here now that would like to say something. I don't know, Linda and Kevin and Karen, and let's see, who else? And of course, is going to play a part of it. So if you...
Commissioner Cooney is also on.
Okay, and Mary Cooney, what are the three commissioners? Are they on some kind of a trek? GSI. Oh, GSI. And Mary's there. We have already met and a couple of occasions, and try to get ourselves structured enough to know what obligations we have in regards to this. We have met separately as a group. Ann and I have spent, I believe there's a cot upstairs now that says Chuck on it. But that's all right. You can say Chuck as long as we have and are able to do it. So if any of the committee members would like to say anything prior to the vote, we'll go from here.
I'm not a committee member, but I wanted to just advise the committee of my strong opinion that we should do a national search. So I hope you will be considering that. Thanks.
We are. Okay, thank you very much. Any other comments from board members?
I guess just a question.
Okay, Ben?
So is this vote to create the committee and appoint? Because it sounds like we already have a committee.
Yes, we have.
Okay.
This is just to confirm the people that I appointed to the committee.
So this is to make it official then? Huh?
Yeah, right.
So you can't back out after the vote then today?
Do I hear a motion to accept the resolution, please?
Move approval of Resolution 1804 as presented.
Second?
I'll second.
Okay. Any further conversation, discussion? All those in favor signify by aye.
Aye.
Those against? Okay, thank you very much. Let's go to item 8, reports, paddling upstream with health promotion. Kyle, you're on.
I have to go to a school board meeting to plan out the new schools. So I'll sign. All right. You have to sign.
Okay, so thank you so much for the opportunity to come to you today and give you a little overview of Health Promotion Division. You have some handouts that were printed off beforehand that are in your packet related to this presentation. We have 20 minutes for the presentation, so I'm going to be moving quickly to the parts that really matter, and that's my staff coming up and talking about their programs. So as we go through here, key things I want to make sure that you're aware of related to the division is that just becoming more familiar with what the Division of Health Promotion does. Understand some of the key strategies that health promotion uses to address prevention. Learn a little bit more about the activities and programs that address disease and health of Spokane County. And know more about how health promotion and SRHD will be moving forward in the future to really address some of the key risk factors that influence the health of our county. So as we kind of do a brief overview of the division, we have almost 50 staff in our division. We have 16 programs in the division, and they're listed there. Our overall goal, of course, is to reduce chronic disease and injury. Our approach that we use is a comprehensive approach using the social ecological model, which I'll go through a little bit later. And I think that you've seen after every presentation of Dr. Lutz's health officer report, he ends with the social ecological model and the health impact pyramid. Okay, some general statistics. We know that in the state and in Spokane County, there's an uninsured population of adults and children. We also know that there's underinsured population, and this is key because when you're underinsured, you don't have enough insurance to actually cover treatment or any other services because the deductibles may be too high to actually go down that road, especially if I have an illness or disease. One of the programs that Donna manages, the breast cervical and health program, deals a lot with uninsured and underinsured population. We know that place matters. As Linda was indicating earlier, Dr. Aiton talked about place, talked about where you live, and it matters based on what kind of services are available, what access opportunities you have. In Spokane County, we've done that same kind of work, and we've noticed there are differences. And so you notice that on the graph, it shows that in Hilliard, in general, life expectancy is 75. But you go up on the South Hill in Manitou, 86. And then West Central, 75. But you can see there's lots of differences related to census tracts on that map and life expectancy. So just know that place matters, and some of our interventions focus in on geographic locations and try to address risk factors. We also know that social determinants also have a difference, such as if I have a higher income, I'm less likely to have coronary heart disease. If I have more education, I'm less likely to, again, have that heart disease. We know that there's racial differences in health and related to income and also related to education. We know that there's racial differences related to food insecurity and overweight. So there's, and those differences are unique because for those that are insecure, the foods that I have more opportunity or more access to tend to be cheaper foods, which tend to be higher in fat, higher in sugar, higher in salt, which leads to potential health issues down the line. We also know that there's differences related to tobacco use and marijuana use. And this is from our Healthy Youth Survey and our youth experimenting and using tobacco and marijuana. So in health promotion, we use that social ecological model. And as you've seen before, it essentially says that the individual, me or you, are influenced by a number of things, a number of factors in our community, with our relationships in our family, around where we work or where we go to school, in the community that we live in, and we talked about those place matter issues, and around policy and social norms. You know, those have big factors on who we are as individuals and what we do. And each community is different. Each place that we live is different. So when we look at the policy area, what I did was just go ahead and put some of our programs into that social ecological model. So it's not a full listing of each of the programs. It's just an example of the programs that we have that fall into this. So of the programs that address policy within our division are those: the healthy eating, SNAP Ed, active living, tobacco, vaping, marijuana, community health workers, as an example. We also have programs that work on the community level areas. We have programs that work in the organizational areas. And then we have programs that work interpersonal and also in the individual. So the key thing here is that we try to work comprehensively across the social ecological model. We know if we're able to do that, we're better able to really address the risk factors that are there. For example, we sometimes really like to put trails out in communities to increase access to walking opportunities or biking opportunities. Yet, if we don't do individual education about where the trail's at or how to use the trail, it's not going to be used very often. Or if we don't create some policies around how the trail is accessible, around systems, or if it's just a trail that's not accessed, you can't access it for anywhere, or it doesn't go anywhere, again, it's not going to be used very often. So that's some of the key aspects of how to use the social ecological model. So WIC, when they do nutrition education and physical activity, really try to work with the active living program on addressing some of the systems and policies to support that. So we work across programs, across divisions, really work inside the health district, and work with our community partners to really try to, again, address these other issues that influence individual behavior. Another thing that you'll hear a lot when we're talking about prevention activities is the notion of upstream, downstream. And so I put together, I apologize for the simplistic graphics. I probably would have been a lot better if I would have had our communications team here help me with this, because they're experts, but unfortunately I didn't. So you have to bear with the simplicity here. So what we've got here is we've got lake chronic disease, okay? Once you're in the lake of chronic disease, you are in there. There's no getting out, okay? What we're trying to do is stop people from flowing down the river into the lake. So that's, we refer to as downstream is the lake. Upstream is anything from the lake and above. So, and that's related to some prevention messages. So when we've got disease river flowing into that. All right, so again, downstream, the downstream factors that we try to address are more individualized education. We try to keep people afloat in the lake, okay? Try to keep them from sinking. And those are awareness, education, knowledge building, so those tend to be more individualized based. So if we put the social ecological model on this, that tends to be the individual interpersonal kind of activities. We do a lot of work in this midstream area, and that midstream area tends to cover, again, our organization, our community, our interpersonal kind of risk behavior factors, again, to stop people from flowing into that lake. The upstream areas tend to be the large social policies, areas that we can address really upstream, that is really at the start of the river. It's really way up front. And so those are those activities we look to kind of really address. Now, another way to look at that, again, is I put down here as far as prevention activities, and again, thinking about that social ecological model. Upstream, that's social inequities. We address race, class, gender, institutional inequities, business, government, etc., for those upstream. The midstream, again, like I said, focuses on a little bit more of that middle of the social ecological model, environment, community, organization. And then the downstream really works at a little bit more of that interpersonal individual. So if we think of our healthcare system today, much of the work and almost all the money is downstream, right? It focuses on trying to keep people's symptoms where they are. They're already sick. We're just trying to treat them and keep them afloat. if we can prevent them from going down there, that's where we got to be at. That's the prevention that we need to be at to be able to make difference happen. And we do that through system change. We do that through policy change. We do that through these trying to upstream approaches. It's hard work, but we really have to be committed. Question was asked earlier. We've been struggling this thing for years. Why can't we? Systems. We have to be really willing to roll up our sleeves and think about how can we change this system? How can we change the policies that influence that river and getting us into that lake? All right, so now the good stuff, health promotion activities. So what are we doing? All right, so Donna, would you like to come up and talk about some of your work?
My name is Donna Oliver, and I'm one of the program managers here in Health Promotion. I manage our cancer screening program and our SNAP-Ed program, and also our community health worker program, which really touches on both of those and more. So I'm just going to share a little bit about the community health worker approach and how it really intersects, quite frankly, at all of these levels in many different ways. But first of all, I just want to talk a little bit about what is a community health worker. I don't know if folks have probably heard this term. It's maybe a little bit of a buzzword these days. I think all of us can identify with the challenges of that individual level behavior. I mean, the reality is most of us know a lot of the things that we should be doing. Our doctors are telling us things that we should be doing. What still keeps us from making some of those decisions is really quite complex. Busy lifestyles, things we've heard, misinformation, et cetera. Now you layer on some other things like poverty and language and lack of finances for care, and it can be even more complex. But often some of the most influential things in our life are at that interpersonal level. We may hear from our doctor, you know, you really should get in and get that cancer screening. Yeah, I really know I should do that. And yet, when somebody that we trust and we know tells us about their experience and what happened, and if they wouldn't have gone in for that screening, and guess what, it wasn't so bad, et cetera, that often can carry a lot more weight. That's really what we're talking about when we talk about the definition of a community health worker. They go beyond what we are all of us well-intentioned and well-educated folks are doing to really be able to have that lived experience. And that's a piece that we often can't get at. I know that Kyle has a lot of great education and probably a lot of knowledge in what we do in WIC, but I can pretty much guarantee he has not breastfed a baby. And so in WIC, we have breastfeeding peer counselors, people who have actually been in the WIC program. They've had babies, they've dealt with those challenges, and that adds a whole nother element of interacting with those clients. It is not to replace the work that we're doing around education, physicians, social workers, et cetera. It's to enhance. It's to increase the reach and the effectiveness of what we do. And so there are so many areas in which community health workers can really play a part and be at the table and improve how we're doing the work that we're doing. So, you know, why? It's really this, they're really linkages between the social and health services and the communities that we're trying to serve. And that benefit goes both ways. It's not only enabling us to more effectively do things like outreach and education and be able to address perhaps some of those cultural pieces, but it's helping the organizations that are trying to serve those folks better understand them too. It's not enough to just tell people you should go out and exercise more. You don't have a lot of money? Well, just walk, it's free. But if you don't know that they don't feel safe walking in their community, that can be a barrier. It's not enough to say, just go to the food bank, they'll give you fruits and vegetables. If you don't know that they have to ride the bus and carry them, or ride 2 buses, and fruits and vegetables are heavy, you may not know that that's a barrier. Those are great examples of things that someone who knows them or is part of their group or community can understand and perhaps help to overcome. So quite frankly, there's some great evidence around the effectiveness of community health workers, and there's a lot going on around it. This is really an umbrella term. Folks may be called a community health worker, they may not. But it's an umbrella term for a lot of roles. In WIC, they're called, breastfeeding peer counselors. There may be advocates. Promotoras in the Hispanic community have been around for years. They're an example. So there are tons of terms for this, but what we really want to come back to is they aren't just somebody that you call a community health worker to go out and do good work, who really cares and knows and understands. They are somebody who has that lived experience that they're able to bring to the work. And it can involve a variety of work, everything from outreach, education, helping folks navigate the systems, connecting to resources, advocating for the communities they serve, et cetera. So we really see that this intersects on every level, quite frankly, of the socio-ecological model. So some of what we are doing in our community health worker program is around support and connection with the variety of folks who are working as community health workers in our community. We actually do a lot of this work on the regional level, although the majority are in Spokane, as we know, just from a population standpoint too. We, first of all, have been involved in implementing the community health worker training since 2012. This is kind of a foundational training that the Department of Health implements, and we have actually been an independent trainer for Eastern Washington in partnership with them. We're the only ones in the state who are taking that on independently, and what's nice is that as opposed to what the Department of Health is doing in other areas where they have great staff who go out into a community, conduct the training, and then go back, we're local. And that's been very beneficial for us to add some other elements and connection to folks who go through that training. This is really just some, like I said, foundational skills that everybody who may work as a community health worker should have, and then they have a variety of optional topic choices that they can also have access to for education. And since 2012, we have trained around 400 people through that training, and about 300 of those have been in Spokane County. One of the big things that we've heard since we've started that training is that people still have a desire to be connected to each other and to the resources and the ongoing information. And so we have actually implemented in the last couple years a community health worker network for those who are interested in that connection, and that is really blossoming. At this point, it involves a lot of community health workers, but also some of the agencies and folks who actually support the community health workers too. And this is, everything from different healthcare settings to volunteers in the community to resource organizations, et cetera, being able to come together, learn from each other, and learn how they can really enhance what they're trying to do. So my graphic is really an example of the training and the network being at the center of some of these examples where we are utilizing community health workers. And some of the programs, like I mentioned, at the health district here, not only WIC, you're going to have some folks talk about Walk, Bike, Bus. They utilize ambassadors from the community. I'll talk in a minute about some things we've been doing within some of the low-income communities. Those are just some examples of programs and healthcare settings, social services, but really, especially public health. It's really that ability to connect that world with the communities that we're serving and to elevate their voice in this process. So another thing that we do in our program is a few examples of really applying these. One of the things that we've done over the last year and a half or so is partner with one of our federally qualified community health center clinic systems with CHAS in seeing what would it look like to have a community health worker as a part of the care team. And what they were really interested in was trying to see if they could improve their connection with the Marshallese community. They had a lot of patients who were from the Marshallese community, but they were really struggling to engage them and just to get them to come into services. And through our partnership, they basically recruited and hired someone from the community to be a part of that team, and went through the training. There was some focus in this particular project. Part of it was because of the grant funding that was supporting it, but around some screenings, with cancer, diabetes, blood pressure, but for the most part, just getting them to come into the clinic. And so this is just one example of one of the areas that she worked on. In a very short time, just having this gal on board, they saw a significant increase, for instance, in the number of Marshallese women who actually came in and were screened for cervical cancer, of which, there's a lot of risk in that population. What actually happened too, by chance, is shortly after this, the community health worker actually got quite ill herself, and she had to be out for a few months, and that graph took a sharp dive. The evidence was pretty stunning. Since then, what we've really found from them is that the system itself and a lot of the staff really have seen the evidence of having the benefit of having community health workers, and they've actually got a few more on staff, and they're committed to really growing that for their clinic. Another thing that we've been doing for a few years now is we also have a community health worker model within several different low-income housing sites. We call them community health advocates, but they are a type of community health worker, and these are folks who live there, who were kind of natural helpers, who are recruited and trained and are mentored to do things like, promoting healthy eating and physical activity and connection to resources within their community. And the benefits have been, like I said, both ways, where we have been able to identify ways in which we can help bring things into their community, and they can give feedback to those organizations that are trying to serve them. So those are just a couple examples in our area, and I will let the rest of the folks take on their part.
All right, great, thanks. All right, so Helene, you want to come up? Helene Dewey, our Healthy Activities Active Living Lead.
Thank you. Thank you, Chair Hafner and members of the Board of Health. Again, my name is Helene Dewey, and I am the lead for the Active Living team. And I'd like to do a shout out to my Active Living team, Annie Zotkowski and Jenny Arnold over there. Okay. So I want to talk about a little bit of a focused approach that we have in active living, and that is through promoting active transportation. And active transportation is just really simply human-powered transportation, so walking, biking, or taking the bus instead of driving single occupancy vehicles. And the graphic on the bottom shows the correlation between walking, biking, and taking the bus to better health outcomes, because we get that question a lot, like what is that connection? Yes, it increases physical activity, but that physical activity, better air quality, has better health outcomes for everyone. And Kyle talked a lot about the socio-ecological model, and within our active living team, we ensure all of our programs have strategies that really touch on each piece of the spectrum in the model. Overall, we promote policies and implement programs that make the active choice the easy choice in our community, the active choice the safe choice. It's something that safety is definitely a priority of ours, making sure that we meet the safety needs, that people can be active safely. One thing that we always ensure as well is that the programs that we develop and implement meet the needs of the populations that we serve. We know that there's not one single program that is one size fits all. And so this graphic shows, I'm sure everybody has seen the baseball field to show equality versus equity. This has bikes. I liked it. So it shows that we all have different needs. And we need to make sure, and we definitely make sure here in the Health District, that our programs do so. And one of the programs that I wanted to talk to you about today is programs of our Safe Routes to School. It's the walking school bus. Raise your hands, everybody. Anybody heard of the walking school bus? awesome. So it was in the Spokesman last week. I think it was recently highlighted on Creme 2 News. But again, it's people-powered transportation. It's walking kiddos to school. So we have a partnership with Spokane Public Schools currently, and we have paid staff people funded through a grant through Washington State Department of Transportation through the Transportation Alternatives Program that pays adults who are federally background checked and trained, trauma-informed, to walk through the neighborhood picking up kiddos. This school is Stevens Elementary that currently has 65 plus kiddos participating in the walking school bus. Currently, just today, we're at 3 schools. Within the next few months, we'll be at 6 schools. And our goal by 2020 is to be at 14 schools. We have applied for additional funding for the years 2021, 2, and 3 to really grow this program to not necessarily rural communities, but those school districts that still have the infrastructure for kids to walk, but still need a program like this. They may not need 3 or 4 routes, but maybe just 1 route at their school. But we want to make sure that this program is accessible to all. And if schools are interested outside Spokane Public Schools, we're always willing to train staff if they're willing to champion the program at their school. The leaders are parents. They are some para-educators at the staff that want to pick up a few hours. There are people in the neighborhood. What we didn't want is people driving to go to the school to walk kiddos. So there are people from the neighborhood. And with each adult, they have mentors. And these mentors are folks that volunteer. Right now, we have a partnership with University of Washington medical students, so students that are going to be doctors. We have a partnership with Gonzaga University in their sociology department. And we also glean from Local 29, which is the firefighters union, Spokane Medical Society, and just anybody really wanting to get out there and to help out with the program. We make sure that the kids in the morning arrive to school for breakfast, and all of the schools that we're at currently provide a free breakfast. The mentors usually sit there and hang out and talk with them while they're eating the breakfast. And in front of you guys, you do have a fact sheet and some letters of support. The fact sheet just highlights a couple of the milestones that we've met. Because we're public health, we like to evaluate the heck out of everything that we do and be held accountable to our grantors. And so we are seeing really good health impacts and behavior changes with physical activity and safety. But we're also seeing an increase in sense of community, addressing parental concerns around safety, better classroom behavior. And the one that really excites me is the better attendance. Statewide, all of our school districts are seeing chronic absenteeism issues, and those issues lead to lower graduation rates. And in our program, the kids that participate have better attendance, and we have a shared use agreement with Spokane Public Schools to be able to show that. And with that, I'll turn it back over to Kyle. Thank you.
All right, thanks, Helene. Okay, so looking towards the future and just kind of summarizing where we're at here, we want to continue to move upstream, continuing to really try to address those systems policies and that comprehensive approach. We're going to be implementing our new strategic plan here soon, which has definitely some pieces around that upstream approach. We want to increase education and awareness about inequities, about the things that are shaping our lives and moving forward. So increasing knowledge within our community. We also want to seek to consider having the health impact of all policies. When we're thinking about policies, we got to ask the question, what's this going to do to health? What's this going to do to the health of our community? What's this going to do to the health of the population that it's going to be impacting? So we have to have that health question asked with each policy. And we have to align our prevention efforts to increase overall effectiveness. We have to work together. Cities, counties, staff, nonprofit organizations, for-profit organizations, we all have to fit together in a puzzle so that we can have a healthy community. I think everybody's goal is to have a healthy, happy community. Let's all do this together and align our efforts and not have siloed attempts to try to do this. But let's get together and actually go the same direction. So that's about HP. So thank you so much.
Any questions for Kyle?
Any questions?
I had the privilege not only visiting Kyle's division, but the other divisions. I want to make sure everybody understands that it was a privilege for me to attend each and every one of those divisions. But
It was our privilege, Chuck. Thank you so much for
they did give me apple pie, but they did not give me any apple pie. So there was a nice for me to be there.
You know, you do what you got to do.
So if any of you wish to visit the divisions, you have that opportunity. Just make sure ahead of time you make arrangements whether you want apple pie or cherry pie.
There you go.
Doctor, Don?
Is that on? I just had a question. Are the community health workers paid or volunteer or both?
Both. Yeah, so
And
we
what
have.
percentage is
We
volunteer?
Yeah, we have a program right now, the Community Health Advocates Program, and we use stipends to kind of help their, with, cover some of their interests in the program. But we have volunteers that also address this. And then at the other level, there are paid community health workers that work in medical clinics and other kinds of organizations that do that work as well. So it's a spectrum. The community health workers are all the way from volunteer to full-time staff in organizations.
But I will say, and it kind of links to some of the legislative piece that you have here, it's a challenge because of the insurance paying for the work that a lot of community health workers are doing. There's the ability to code for that work, but still getting that payment piece there is a bit of a challenge. So as part of one of the legislative pieces here is to get some of the recommendations that came out of statewide task force to move forward and kind of solidify some of their recognition and their values so that they can move some of that forward. But at this point, it's clinics funding it themselves, or it's grants for some volunteer situations.
What percentage of volunteers?
I would say it's
Just a
small
guess.
percentage at this point of ones that I'm aware of.
Okay.
Yeah, official volunteers, but we all know those people that live in our communities and neighborhoods are the go-to people, are the ones that have this really big heart and have this care so much for what they do in their community. And so those are the unofficial community health workers that we also try to get in touch with around increasing knowledge and awareness of some of the other things that are happening out there.
Thanks.
Great, thank you.
Any other questions?
Quick question
Okay,
about that.
Andrea?
The walking school bus, which is a really neat program. That's a great presentation. But it was funded by the DOT. Is this an all program in Spokane, or is this something that's been done across the whole state, Seattle?
Yeah, this is a statewide effort, and each year, communities put in their application to become a funded Safe Routes to School community or school district. There has to be a plan in place, development of a plan, and to get kids to school safely, especially if they're walking or biking. Anything else, Helene? Group? Okay.
Kyle, I'd like to see you try the high school level. No, I wouldn't just. Okay.
Exactly.
Can you imagine high school kids walking to school?
Yeah, exactly. All right, thank you so much.
Okay, thank you, Kyle. Okay, at this stage, we're going to go into executive session, so you're on.
All right.